Thank you very much, Simone, and thank you very much all for attending this. I'm going to give you a presentation which I gave to the Royal Statistical Society for the Bradford Hill lecture not so long ago about improving health faster and a more strategic approach to randomized trials and meta-analyses. Just So if you look at what we currently do in clinical trials, we typically ask the question, does this new intervention improve outcomes for this particular disease? And, historically, that's what we've done. And we know this process can take up to 20 years from an intervention leaving the lab to actually entering routine practice. And if you talk to our industry colleagues, that can cost up to £2 billion. And of course, that's a well-trodden path that we've done for many, many years now. However, we know that for many of our diseases, and I've listed a whole range of them there, and you'll have your own list as well on this, is that this model has led to little or no progress, including motor neuron disease, progressive multiple sclerosis, Parkinson's disease, dementia, a range of cancers there, advanced and lung kidney disease, and a number of other diseases. We've made little or no progress for absolutely decades in these diseases. And if you look at some of the challenges that underlie this lack of progress, is that in most of these diseases, it's not that we've short of phase two signals. Actually, we've seen quite a few phase two signals. Um, but those phase two signals of activity for interventions have not translated into improved phase three outcomes of efficacy. And if you study the literature or you look at your own experience, the failure is often at the randomized phase three stage, which is pretty much of a disaster to fail there. Many phase three trials do not show superiority, and if you look across diseases, that's approximately half of all trials. Of course, in diseases like Parkinson's disease and dementia, that's 95 to 100% of all phase three trials have not shown benefit. And we know that phase three costs about 75% of all of the evaluation costs of the process. And of course, those of us who do them know that phase three trials are just much harder to do. They cost many millions of pounds, if not hundreds of millions of pounds, include many hundreds, if not thousands of patients, many, many sites, and many, many years. And a good example of this sort of challenge and lack of progress is in Parkinson's disease. You'll all be familiar with this disease and probably know somebody with this disease. And this graphic here shows you the situation in Parkinson's disease. The brown blocks show you the phase two trials. The yellow blocks show you the phase three trials, and the dots between show you the time between the phase two and phase three trials. So you can see we've had lots of phase two signals, all of which have not given us any element of disease-modifying treatment. And we know we've only got symptomatic treatments for Parkinson's disease. So how can we change our thinking particularly in these diseases? So actually, one way is to actually go back to basics and say, are we asking the right question? Can we change the question from, does this specific intervention improve outcomes for this particular disease, to how do we improve outcomes as quickly as possible, particularly for these diseases? So just a simple change in that question can actually lead you to thinking in quite different ways. If you change the question to how do we improve outcomes as quickly as possible, let's say for Parkinson's disease, then you actually come to quite a different sort of approach and way of thinking. And it's quite simple to say, well, actually, one simple way of doing that is to, rather than focus on one intervention at a time, evaluate many interventions in one protocol. Because where we're failing is the phase three stage, and that's where all the financial action is, focus on the phase three stage. acknowledge, given what we know about these diseases and the interventions that we're testing, that many of those interventions will not succeed. And we know that information will emerge from both the trial we're doing and from data outside the trial to plan to adapt the protocol as we go from data within and outside of the trial. And so those principles are very easy to come to when you change that question. And that's led to this concept of platform protocols. And under that umbrella are lots of types of different types of protocol that we can see: multi-arm, multi-stage platform trials, basket trials, umbrella trials, and other types of trial as well, which have these characteristics. But the characteristics are really quite simple. And one area that we've developed and particularly worked on for over 20 years now is the idea of multi-arm, multi-stage platform trials. They give you more and faster answers, and the concept is quite simple. The traditional approach is stated above, as you can see, testing treatments one at a time, and then when they fail, going on to the next treatment. Well, rather than doing that, can you line these up? Test a number of treatments all at the same time at various points in time, compare those treatments against control. For example, treatment A against control, treatment B against control, treatment C against control, and see if there's value in continuing those, evaluating those interventions. If not, stop them and then carry on with those ones that there's value in, or some evidence of activity to justify carrying on evaluating further patients. At various points in time, you might also introduce new treatments like treatment D here, and then treatment D itself might become the standard of care at various points at a given point in time. So you can see that the concept is really quite simple. The challenge with some of these platform protocols is that most of the protocols have been developed for phase 2 trials, and actually that's not where the problem is. The problem is not to get more phase 2 signals, although the platform approach will help us get more phase 2 signals and perhaps will get us there a little bit more quickly, but it won't solve the problem. Many methods will have developed in that area, but these will have limited impact, in my view, because the problem is at phase 3, not at phase 2. Another thing to note in this area is that actually industry will usually be only interested in a single treatment for a given disease at a given time. It's not in their interest at all to evaluate many treatments for the same disease at a given time, any individual company. So academia is uniquely placed to do such sort of platform trials evaluating many interventions, and experience supports this. They don't solely do them, but they're the large majority are being done in that environment. And as I'd repeat that unfortunately most applications of these sorts of trials have been in the phase 2 setting and not in the phase 3 setting, which is where the big need is. And you can immediately see that there are considerable advantages of this approach. And I'll show you an example in a minute, that they're faster because they're testing multiple things at the same time. They cost less. We've given a rough figure. Don't know how solid it is, but a rough figure that you, for every 4 comparisons that you put in 4 research arms, you get one of those free in that in a platform trial. You facilitate recruitment. They're some of our fastest recruiting studies that we've ever done, and we might explore why that might be the case. And of course, they have a great deal of flexibility. You can drop and add treatment arms. So let me take you through an example. Probably the first formal sort of a multi-arm, multi-stage platform trial in the modern era was the Stampede trial, which we started designing in about 2000, launched the trial as a 6-arm, 3-stage trial in 2005. First discussions about adding arms was in 2007, and more formally into a platform trial in 2010. Since that time, we've added 5 new research arms. Um, and alongside that, in the US, the iSpy team led by Don Berry were looking to see what they could do in breast cancer. And they launched the randomized phase 2 platform in in breast cancer in 2010. So just around the same time, maybe a few years later. And they're evaluating many new drugs. But as I say, that's a randomized phase 2 platform, not a phase 2, phase 3 trial, or not with a phase 3 component to it. So let me tell you what's happened with the Stampede and prostate cancer, this trial, which is now 21 years old. About just over 1 million new prostate cancers worldwide a year. In 2005, when we were sort of launching this trial, standard treatment for men with high-risk prostate cancer hadn't changed for 40 years. It was just hormone therapy. In fact, in 40 years before then, in the 1960s, people got the Nobel Prize for the introduction of hormone therapy for prostate cancer. But since then, there's been no change in treatment. Median survival for men with prostate cancer was about 3 years, metastatic disease. So we planned this phase 3 platform trial in prostate cancer. And over that 21 years, we've evaluated a chemotherapy agent, a bisphosphonate, a COX-2 inhibitor, radiotherapy, some of the newer agents or the newer therapies, what are now called the ARPs, the androgen receptor signaling inhibitors, metformin, an old drug used for treating diabetes, and estrogen, hormone replacement therapy that often menopausal women use to treat their menopausal symptoms. So we've evaluated old drugs, new drugs, repurposed agents, and non-drug interventions. And this is what the trial schema looks like. You see the standard of care at the top, recruiting from 2005, continuing until 2023. The dotted line following that shows you the follow-up, and the solid line shows you the point of analysis. You see we started with arms B, C, D, E, and F, 5 research arms. And then we've added 5 research arms over time. And you can see that the accrual periods, the dotted line showing the follow-up after accrual, and then the solid line showing the solid block showing the time point of analysis. And summarizing all that work over 20 odd years, we've recruited 12,000, more than 12,000 participants, more than 120 hospitals in the UK and Switzerland. There have been 5 changes in standard of care over that time, and they've been incorporated within the Stampede protocol. We've adapted the protocol as we've gone. 4 of those changes of standard of care have come as a direct consequence of the results of Stampede itself, because the results have come out at various points in time showing benefit, and they've been incorporated and both into Stampede and into routine care. And we've had better survival as a consequence. We're now estimating that the 3-year median survival for men with metastatic disease has now improved to 8 years as a consequence of these 5 changes in standard of care, 4 of which have come directly as a consequence of Stampede and other trials asking the same question. You can see if you tried to make that change, these changes in any other way over a 20-year period and improve survival, median survival of 3 to 8 years, it would have taken you generations to do all that, couple of generations, I guess, to make all those changes. We've done it in 21 years. So you can see the power of this sort of approach. The reason in my previous slide I'd said that this was the first formal MAMS platform trial in the modern era is actually, of course, there's nothing new under the sun. And if you go back in the literature, the MRC did this sort of trial in the 1950s in TB. They did a basket multi-arm, multi-stage platform trial. And there's the details, but you just have a look at this is the actual picture from the paper in the 1950s, taken from the Lancet. You can see you don't need to know the details of it. You can see it looks exactly like the picture I showed you for Stampede, just with different groups. It's a basket trial, so it's got lots of different groups, 1A, and then the 1B group, etc., and then the 3A and 3B group. But you can see it's very, very similar. They, of course, didn't allow for all of the complexities in terms of multiple comparisons and correlations and adaptation implications that were relevant at that time. So Possibly the stats wasn't as solid as it might have been, but at least the principles were there. So some of the strategic issues that these trials raise, if you're going to do these things, is you need to think in a different way, in a different time frame that we do for our typical trials. You need to plan for a 5 to 20 year time frame. You get funding in stages from many different sources. Actually, patients are key to their development, design, funding, conduct, and reporting. In fact, without the patient voice, these things would not have happened and will not happen. They can be a challenge for the Central Coordinating Centre, and I'm happy to go into some of the challenges. Um, of course, because there are so many moving parts and so many things going on here, that the data monitoring key, and it has lots and lots to do. So actually, you want to get a data monitoring to, which is both very good, but also willing to take on quite a bit of work. In in truth, of course, they're challenging to develop, fund, and run. And actually, you have to learn to do things in parallel rather than sequence. In our trials arena, we're used to doing things in sequence. You do this first, you carry on, you do the protocol, you do this, you do that, you do, and actually, you have to do things in parallel. What we've also found is a different chief investigator for each arm can help. And there's a number of other things that I've put there, which we can pick up in discussion. In terms of design, some of the challenges are, and some of the things that you need to look out for here is actually strategically, you have to plan this really quite thoughtfully. And one of the things to think about if you're going to do these things is to choose research interventions with different modes of action. And there are a number of reasons for doing that. Firstly, you maximize your chance of success. Why would you have Tweedledee and Tweedledum in the same trial of two different interventions where there hardly any difference between them when you could have two different types of therapy, which actually maximizes your chance of making progress? We also know that actually for most of our diseases, we need to have combination therapy if we're really going to hit a home run. If we're going to get towards cure for some of these diseases or real major improvements, combination therapy is going to be the answer. And with therapies with different modes of action, you have a potential for adding them together, and that's how we've seen the rapid change in survival for men with metastatic disease with the hormone so metastatic disease with prostate cancer, adding to hormone therapy. We've added all of the active and effective therapies. And finally, there's a statistical reason. You allow the type 1 error to be pairwise. Each of these comparisons can be seen as a two-arm trial, just going on a large protocol rather than family-wise. And again, happy to pick that up. I won't go into all this all the rest of these comments. Happy to pick up any of the rest of the comments on this slide in the discussion. But the first bullet is the most important here. Uh, I won't spend time on this to say you do need to work through why you might have the pairwise error or the family-wise error in this situation. And the pairwise error is like considering them as two-arm trials, treatment A versus control, treatment B versus control, treatment C versus control, as independent comparisons. A family-wise error is any error that you can make in A versus control, B versus control, C versus control, any error that you can make. And that's a really very high hurdle to jump. So there's a very good reason for concentrating on the pairwise error, and that links to the other points that are raised. I won't raise any, come to any more points on this slide, but again, happy to pick up any of these points in discussion. Once you think about the adaptations that you can do, actually, you can do quite a lot of things. And what we've done in Stampede and now starting to do in other trials is to drop research arms, add research arms, change the control and research arms, typically by adding the successful interventions from within and outside the trial, which I've shown you. I didn't show you how we've done it in Stampede, but I've shown you we've done it in Stampede, changed the control as we've gone. We've changed the primary outcome measure because of data outside of the trial. We've adapted the sample size for a variety of reasons as a consequence, partly of changing the primary outcome measure. And we've split the population into subgroups of the different types of patients, particularly when we're looking at targeted therapies. So whole hosts of adaptations have gone on during the course of this trial. And if you look at the numbers of trials, now this is a bit of an older slide now. Actually, more than 100 randomized trials using some sort of MAMS platform trial design have been used, and or some variation of it. And of course, many of you will be familiar with some of these trials, particularly during the COVID pandemic. There were a number of trials which use this sort of type of design. I'd like to show you how we've sort of evolved this thinking a little and taken this to the and applied it to the basket situation. And take you through this by example. Let me just check the time. Okay, 23 minutes. So I'll take you through the Rossini platform. Those who are involved in the surgical trials or surgical settings will know that wound infection after surgery is one of the most common types of infections worldwide. It's a big challenge worldwide, and it's a major issue for the patient, significant morbidity involved, and often time spent in hospital, and sometimes leads to death. It's, of course, a major issue for health services. And if you think of the number of surgeries that go on around the world every single day, it's a huge, huge problem. The evidence for reduction of surgical site infection is very, very poor. There's conflicting recommendations and only generic guidance from major organizations worldwide. So we've planned this trial, which is just about to start, and it's the Rossini platform. It's a basket factorial MAMS platform designed for those who like naming things. It's multiple parallel, separately powered MAMS platform trials across different specific body types, all in one overarching protocol. And this is the design. So here we've got different types of surgery: breast, vascular, cardiac surgery, neurosurgery, amputations, and thoracic surgery. Actually, thoracic surgery has changed now, but for this talk, this is fine. And what we're testing is a number of interventions in each of those surgical settings, number of wound infection prevention interventions, both preoperatively, intraoperatively, and postoperatively. And some of those interventions are common across different surgical settings. Some of them are different. And we're doing this in a factorial sense, testing 3 interventions in each to start with, and adapting the protocol as we go. And I've shown you some of the potential adaptations. Can we move successful interventions which are, so let's say which will occur, let's say in the vascular setting or the cardiac setting, or in this case the vascular setting, into let's say the cardiac setting, because it may be relevant. Can we also use information on evidence that an intervention isn't working in a particular basket to stop the interventions in other baskets? Can we further supplement the surgical settings like neurosurgery, which will be much less common than, for example, a breast surgery or cardiac surgery? Can we supplement the information on the interventions in neurosurgery by information on that same intervention in the other baskets, such as breast and cardiac, which recruit much more quickly? Because we know we'll struggle with getting to the number of patients. So you can see how complex this will be. This trial has just been funded by the NHR and is aiming to recruit about 27,000 patients. And these are some of the calculations that we've done. 26,000 patients, sorry, I got the number wrong. In terms of platform trials being done, now this sort of idea is taking off, particularly in areas where there are either many things to evaluate and/or we've made little or no progress for many years. And you can see a whole range of diseases and areas that this idea is being applied to there. That's just with our knowledge. Of course, a number of trials are going on without our knowledge, and That's perfectly okay, appropriate and good to see. Um, you might ask, when should you prioritize such a strategy? And, you know, you might argue at first flush that it's when you've got lots of patients available, when you've got short-term outcomes, like in the surgical setting, it will be sort of morbidity by 30 days, or when there are large funding pots available. Actually, it's exactly the opposite. Of course, they're good when you have got all that available, but if you've only got a few patients or got limited number of patients available, and or you've got longer term outcomes and you haven't got um, funding is limited, it's even more important to do these things, because if you're going to make progress in reasonable timescales, then you need to be as efficient as possible and evaluate as many things as you can within the timescales that you have and with the funding that you have. Of course, it would be more expensive than doing a single trial at a given time, but strategically over time it won't be, and you'll get your answers much more quickly. Um, my own view is that actually you should prioritize such a strategy when progress has been slow. So that's where we focused on, because there's a desperate need in those situations to change the game, change. You also got to have a number of new interventions with different targets available. No point in doing it if you haven't got new interventions available or that are worth evaluating. You've got to get patients and enough doctors and researchers on board. Not everybody, not everybody. You'll get always there'll be people who throw rocks at you, but you don't need everybody on board. And of course, you've got to get the funders on board. I'll summarize this all at the end. In the last 10 minutes, I'd like to just give you a little bit of a sort of a discussion of meta-analyses and some of the challenges and issues with meta-analyses that I see at the moment. And this is work done jointly, and all of the work that I'm presenting has been done jointly with a range of different people, and I'll acknowledge that right at the end. So what are the issues in terms of meta-analyses, and how can we improve them? So, firstly, we've got to acknowledge that meta-analyses seem to be at the pinnacle of the evidence base. That's where, if you look at most evidence-based structures, they're at the pinnacle of that evidence base. And of course, a good protocol is a requirement for and often now you see a good protocol for meta-analysis. However, what everybody seems to forget, omit, almost turn a blind eye to, is that they're retrospectively written. They're nearly always written after many of the trial results are known. And this just violates most of the basic principles of RCTs. If we insist that everything is pre-specified for the randomized controlled trial, it seems bizarre for us then to accept an analysis and a protocol which violates all those basic principles of RCTs, which because you're not pre-specifying. And of course, there's dangers of considerable biases creeping in. Even worse than that, of course, those of us who are involved in this area know that there are multiple meta-analyses often done. And I've seen situations when there are more meta-analyses than there are trials making up each of the meta-analyses. And of course, they'll have different inclusion criteria, biases, etc. So it's a real challenge. So if we go back to the fundamentals here, what do we try and specify before any data are collected in a randomized controlled trial? The hypothesis, the sample size, the estimand, the analysis plan, secondary outcome measures, analysis and interpretation of subgroups. If we didn't do that, the trial would be regarded as not adding to the scientific base and rejected by the peer reviewers and by journals. Actually, meta-analyses violate all of those principles the way we do them currently. And I'm not sure how we've got ourselves to this position. One of the reasons I think we've got ourselves to this position is that we say that's the best you can do. How can you do better? That's an argument, isn't it? it's the best you can do, so you should do it. Well, actually, it's not the best you can do. And we're starting to show that, and others, not just ourselves, are showing this, that actually you can do prospective adaptive meta-analysis of aggregate or individual patient data from randomized trials. It's unbiased, timely, and reliable. And in this concept, it's quite simple, again, quite simple concept. You treat the prospective meta-analysis as a trial itself. So what do? You start early whilst the trials are ongoing and yet to report, liaise with the trialists to get more information on the trials, predict the earliest timing of reliable meta-analysis, develop the protocol and collect the data before any results are out or before the large proportion of results are out in the trial, and interpret the meta-analysis, taking out count of all of the available and unavailable data. And I'll show you how this might work. This is an example of salvage radiotherapy versus early radiotherapy for prostate cancer. And there were 3 trials ongoing. We planned the prospective meta-analysis in 2011. And what that did actually was brought the groups together. We agreed that the meta-analysis would have a joint sample size across all the trials. We just justified the change to the definitive outcome measure for one of the trials because it was going for overall survival. It could go for metastasis-free survival, and the meta-analysis would take care of OS. And actually, it saved that trial because otherwise the trial would not have been large enough to get that data. And the timelines remained long and challenging. And this is what actually happened. The meta-analysis protocol was registered at the end of an accrual of during follow-up rather of each of those trials before the results came out, and the trials and the meta-analysis were published at the same time. And this was the result, each of the individual trials there you can see, and it showed actually that immediate radiotherapy, if there was a benefit, it was very, very small. And it wasn't conventionally significant, no real sign of benefit, but if it was there, it is there, it's tiny. And these were all published at the same time. I'll show you an example in COVID-19 of the anti-IL-6 agents, hospitalized 27 trials from 28 countries, just over 10,000 participants. 18 of those supplied results pre-publication. So we could plan the meta-analysis and discuss it with them and the timing of it with all of the trialists, and 18 of them were willing to get on board. WHO facilitated that. All of the clinicians around the world got together and they endorsed both the prospective meta-analysis approach and the guideline that would come out of it. And it was published exactly on the same day. The meta-analysis and the guideline that the WHO came out with the IL-6 results are all published on the same day. And these were the results that the anti-IL-6 agents reduced 28-day mortality, especially if given with steroids, which then becomes standard of care. Probably less of interest in the lack of steroid when there was no steroids. One final example I think I'll give you is adjuvant aspirin for colorectal cancer. A number of trials there is being shown, all going at the same time. We've identified the trials in 2020, registered the protocol in 2023, as you can see there, and we're planning the analyses to bring these all together under one umbrella in a meta-analysis. The gains for this are considerable. Because we can do this all prospectively, there's no bias. Trialists are giving us key input into the protocol. We can pre-specify and pre-power subgroups and side effects, and we can predict the earliest opportunity for the definitive results. The gains for the trials is that they publish for themselves, of course, their own trial, but they say they're contributing to this larger goal in the various ways we've discussed in these meetings. And with this approach, if you specify all of these things before any data are analyzed and reported, actually you satisfy all of the criteria that you're asking the individual trials in the meta-analysis to satisfy. As I say, I think it's bizarre that we pose all of these restrictions on individual randomized trials, which are which are entirely appropriate of pre-specification, and that we throw them all out of the window for traditional meta-analyses, which are made up of those individual trials, which we insist have all this pre-specification. So in conclusion, I think I'm just coming to an end at about 40 minutes, yes. For the multi-arm, multi-stage platform trials, I'm sure you agree, actually, that we need to make faster progress, particularly in a range of diseases. Part of this is planning for a 10 to 20-year horizon, focus on the phase of 3 evaluation. Researchers and funders should change their strategies in a number of diseases, and it's heartening to see that some of this is going on, but it's still a challenge to get these things over the line. And be interesting to have a discussion why we think that's the case. The public, patient and public voice is key to their driver to this change. And one example I can say for that is a patient voice, a patient partner of mine said to me not a number of years back, is why don't you do all of your trials in this way? And I've never found a good answer to that question. In terms of meta-analysis, I would repeat, it's hard to justify that meta-analyses are currently done can be considered the pinnacle of the evidence base. They just do not adhere to the basic scientific principles that we have in our randomized controlled trials. The argument that that's the best we can do and that's all we can do is not true, I don't think. Prospectively planned meta-analysis using a FAME type approach or other approaches are entirely possible. They do adhere to the basic scientific principles, and I don't know why we throw them out the window. And they can be done. Collaboration is key in this area. Journals, payers, and trialists can really drive change in this area, although actually there's a large group of people who just do not want to change their practice. Again, I'd be happy to have that discussion. I'll finish by just saying the work, as I said during the presentation, presented here is really truly collaborative. All the ideas that are being shown here and the examples have been developed many hundreds, if not thousands, of collaborators over decades. And I'd just like to thank them all. Some groups of people there I've mentioned, but particularly the patients who've been front and center of some of this work and some of the driving behind the work. And I'll stop there. Thank you very much.